Welcome to my scientifically informed insider look at mental health topics. If you find this video to be interesting or helpful, please like it and subscribe to my channel. Hello, this is Dr. Grande. Today's question asks, is complex post-traumatic stress disorder, C-PTSD, different than post-traumatic stress disorder and borderline personality disorder combined? So another way I could put that is, would C-PTSD be different than comorbid PTSD and BPD? So if borderline personality disorder and post-traumatic stress disorder occur in the same person, isn't that really just the same thing as complex PTSD? So to get at the essence of this question, I'll first talk about PTSD. So when we talk about post-traumatic stress disorder, if we look at it in the ICD, International Classification of Diseases, specifically the area around mental health, we see that it can be reduced to a few key criteria. And of course these we would also see in the Diagnostic and Statistical Manual. So we see a trauma, so trauma has to occur in somebody's history. We see a re-experiencing of the traumatic occurrence, like nightmares, flashbacks, intrusive memories. We see somebody avoids places, people, and situations that remind them of the traumatic event. For example, if somebody was in a terrible car accident, they might stay away from cars. Then we see this idea that somebody's under threat much of the time. They feel like they're under threat. It's this sense that one is never safe. And a lot of the time we see this manifest as hypervigilance. Somebody's always aware of their surroundings. So post-traumatic stress disorder is an interesting disorder. About 3 to 8% of people who experience a traumatic event will go on to develop persistent PTSD. So that would be post-traumatic stress disorder where somebody gets the diagnosis and has it a year later or many years later, right? So it hangs on. It becomes chronic. Now this makes it seem like 92 to 97% of people exposed to a trauma are resistant to PTSD, and therefore perhaps experiencing the trauma didn't result in any consequences later on. But we know that trauma is a risk factor for many other mental disorders, including many types of anxiety, like generalized anxiety disorder, major depressive disorder, borderline personality disorder, and substance use disorder. So the effects of trauma can surface in a lot of different ways, cause a lot of different types of damage, and impair functioning across several domains. So this brings me to the idea of complex PTSD. So when I talked about PTSD, of course, as I mentioned, it's in the ICD and in the DSM. Complex PTSD is not a mental disorder in the DSM, but it is a mental disorder in the ICD, which again, the DSM and ICD are essentially competing diagnostic manuals. There's actually a lot of overlap between these manuals. So for someone to be given a diagnosis of C-PTSD, as listed in the ICD, they must satisfy the full criteria for PTSD and have additional symptoms. These additional symptoms are really the key for differentiating PTSD from C-PTSD. So the additional symptoms would include disturbances and self-organization factors, right? So this can be divided into 3 domains: emotional dysregulation, negative self-concept, and interpersonal problems. So right away we see a lot of overlap with these symptoms and borderline personality disorder. So just looking at this really quickly, it seems like there will be trouble differentiating those 2 disorders. We also see that C-PTSD was originally thought of as a disorder that could capture a response to multiple prolonged traumatic events that occurred early in life. So this really emphasizes betrayal trauma, like where a caregiver betrays a victim. So the big controversy around C-PTSD, interestingly, doesn't have much to do with the disorder compared to PTSD. You don't really see a lot of research that argues that C-PTSD is really just the same thing as PTSD. Rather, we see research arguing that C-PTSD is essentially the same thing as comorbid BPD and PTSD. So again, with that comorbidity, is there really any difference between that and complex PTSD? This, of course, actually makes a lot of sense. We know that about 40 to 60% of individuals with BPD will have a PTSD diagnosis at some point in their lives. Now, we have to be careful about how worried we get about comorbidity, right? Because we have to look at the comorbidity between BPD and other disorders. For example, 80% of people with BPD will have major depressive disorder, and 60% of people with BPD will have substance use disorder, again, at some point in their lives. So high comorbidity alone doesn't mean that two diagnoses should really be combined into one diagnosis. Most people would agree that major depressive disorder and substance use disorder both are quite distinct from borderline personality disorder. Now, with this in mind, we might think in terms of comorbidity and personality disorders that the most common personality disorder diagnosis that would be comorbid with PTSD would be borderline. But actually, it's paranoid personality disorder. And then the next one is avoidant personality disorder. Then we see BPD. But either way, there is a great deal of comorbidity between PTSD and BPD. So could CPTSD really just be BPD plus PTSD? Or for that matter, could it really simply be the same as borderline personality disorder, regardless of comorbidity? Well, we certainly do see a lot of overlap. There's really no question about that, so it's hard to dismiss this argument. There are, however, some differences in the way symptoms are expressed. Now, it's easier to make diagnoses when disorders have separate symptoms altogether, but sometimes it's really about different expressions of the same symptom. And when this happens, diagnosing becomes particularly difficult. So when we look at these different expressions, we see the first one would be emotion regulation. Both CPTSD and BPD have this. In BPD, it's expressed as self-harm behaviors and suicidal behavior. In CPTSD, it's expressed as reactive anger and substance use. So right away, again, we see a problem because BPD has reactive anger, that's part of the disorder, and of course it's highly comorbid with substance use. So this is a nice theory about emotion regulation, but this isn't really a great way to tell the two disorders apart. Then we take a look at identity disturbance, right? This again exists in both disorders. In BPD, we see the sense of self is highly unstable, alternating between highly positive and highly negative self-perception. When we look at the identity disturbance with CPTSD, there's a sense of self that's thought of as extremely negative, right? There's a negative self-perception that's relatively stable. So here, with this symptom, identity disturbance, we see a better argument, a better way to differentiate the two disorders. Now, looking over at relationships, we see with BPD this moving back and forth between idealization and devaluation. Sometimes this is referred to as the love-hate cycle. With CPTSD, it's mistrust that causes the relational problems. The individual with that disorder keeps other people at a distance. They have a fear of being hurt. There's really not an idealization phase the same way we would see with borderline personality disorder. Now, we also have some more straightforward ways to differentiate the disorders. For example, we see symptoms of BPD that are simply not part of CPTSD, like frantic efforts to avoid abandonment and impulsivity in at least two areas that could lead to self-harm, right? So those just aren't there. Self-harm actually strongly points to borderline personality disorder. 50% of people with BPD report that they have self-harm. With PTSD and complex PTSD, it's about 15%. So that's a pretty good way to tell them apart, but not, of course, a perfect way. Now, in terms of the chronic feelings of emptiness we see with BPD, this is actually not specific to borderline or CPTSD. So it's a symptom that's not really helpful in discriminating between the two diagnoses. The association with trauma is another way to differentiate. CPTSD is more strongly associated with multiple interpersonal forms of trauma that occurred earlier in life. It's also associated with more impairment in functioning, which I think a lot of people find surprising. This is true when we compare CPTSD to BPD, of course, but also when we compare it to PTSD. Now, outbursts of anger are more closely linked to borderline personality disorder as opposed to PTSD or complex PTSD. Now, another way to look at this problem in terms of differentiating or understanding these disorders is to look at how the symptoms cluster together into categories. This is done for a lot of different symptoms and diagnoses in research. So the question becomes, what do we see in studies that examine traumatized populations? Can they neatly be divided into these three categories: CPTSD, PTSD, and borderline personality disorder? Well, some studies say yes, the symptoms generally do seem to fall into these three disorders. Others say not quite. For example, we see one study where the category is divided up as C-PTSD high BPD, C-PTSD moderate BPD, and PTSD low BPD. So really in this study there wasn't a version of C-PTSD that didn't have some relatively strong connection to borderline features, again moderate or high. Now at some level all this talk about differentiating between these disorders could really just seem quite academic. Does it really matter if we get this diagnosis correct? Does it matter how the symptoms cluster together, or if some symptoms differentiate between the disorders, or if other symptoms are really the same but the expressions are different? Does it matter in terms of helping people? Doesn't it all just work out the same in treatment? Well, here's the problem with this. There's a big difference between how these disorders would be treated and conceptualized. Someone with BPD is thought of as having persistent extreme personality traits, and there's a lot of emphasis on helping somebody to avoid self-harm behavior, in stabilizing relationships, and reducing anger, and gaining insight. There's a lot of validation that takes place when treating somebody with BPD. Now when we look at C-PTSD, this might lead a counselor to use some sort of trauma-focused therapy, perhaps a therapy that involves exposure, like exposure and response prevention. So the treatment for one diagnosis may not be helpful for the other, or it may not be the best choice for the other diagnosis. So taking a step back and looking at all of this, are the differences between these disorders great enough to have a separate classification for C-PTSD in the DSM? I would say yes. I think it's clearly distinct from PTSD. Again, that's not really argued too much. And it seems to be different enough from BPD. And it's important that we use different treatments in many situations. So again, I think it really should be a separate classification, but I do still have some concerns around it. Even though we see C-PTSD in the ICD, and maybe even someday in the DSM, would clinicians know how to diagnose it? There's just so much overlap between the disorders that it's easy to confuse C-PTSD with borderline, and maybe even with PTSD. And it's very easy to confuse C-PTSD with comorbid BPD and PTSD. With other disorders where we see this much overlap and confusion, like avoidant personality disorder and social anxiety disorder, we see a lot of misdiagnosing. So it can be problematic to have these categories that are really close to one another conceptually and in terms of the symptoms. So we really need more research and more trainings on the topic of complex post-traumatic stress disorder. So I know whenever I talk about topics like C-PTSD, there'll be a variety of opinions, people who agree with me and disagree with me, and have other thoughts and examples from their own experiences. Please put those opinions and thoughts in the comments section. They always generate really interesting dialogue. As always, I hope you found this description of C-PTSD to be interesting. Thanks for watching.